what? I wish I could be so brave to have done this when I went and got my master's. So, kudos to you, my dear.
All right, everyone has a handout. This is just like a reference for you guys to use, like a cheat sheet. So you guys don't have to write every single thing down, but write everything down. But in case if you missed anything, a lot of if you want to refer to it later on, you can use it. Okay, so today we're going to be learning about occlusion. Does anyone know what occlusion is or can take a guess at what occlusion is? Nadia.
Isn't it all the maxillary and then mandibular?
Yes, exactly. It's how the maxillary and mandibular teeth, when they come together in a closed position. And do you think that everyone has the same occlusion? Is my occlusion the same as your occlusion, the same as... No, everyone's occlusion is different. Now, in clinic, it's really important to especially pay attention to today's lecture. I mean, every lecture is important, but in clinic, you're going to be classifying your patient's occlusion. They're going to give you a handout, and you're going to classify them. So, each patient you get, you're going to look at their dentition, and you're going to classify each individual patient. Occlusion. Occlusion is the relationship of the maxillary and mandibular teeth when the jaws are in the fully closed position.
We're sorry. We're wondering if the light will affect your videotape.
Oh, no, can you guys see? You guys are good? No,
They're good.
it's fine. I think it's okay.
Oh, okay.
Yeah, let me just take a
Make it look so
Thank you.
You're welcome.
No, don't be
Thank
sorry.
you, thank you. No,
She
you're good.
gets a grade on this.
Good, thank you.
Okay.
You good?
You're welcome.
Yeah, it's good.
Okay, for the mentor grading her, our students just wanted to make sure that the quality of the videotape was as good as it could be.
So occlusion is the relationship of the maxillary and mandibular teeth when the jaws are in the fully closed position. When the teeth of the mandibular arch come into contact with the teeth of the maxillary arch in any functional relationship. Now, occlusion, it's affected by movement, and the range of movement, it affects the patterns the way your teeth occlude. So there's many patterns of tooth contact, and the variety of the range of movement is due to the mandibular condyle within the temporomandibular joint. So that's why your mandible moves around, and everyone's occlusion is different because of that. Now, occlusion development. Occlusion develops in a child as the primary teeth erupt. And later, the occlusion of the erupting permanent dentition is dependent on the primary teeth shedding. So, what that means is, when a child has baby teeth, they occlude in one way. The maxillary mandibular arch teeth, they close in one way. And then, as they're losing their baby teeth or their primary dentition, then the permanent teeth start coming up, and their occlusion starts to change. Sometimes you hear parents saying, because they have a mixed dentition, their children, oh, my child is grinding their teeth. Oh, my child, they're not chewing properly. It's because their teeth, it's a mixed dentition. They have adult teeth and baby teeth mixed together, so everything is not lined up. Also, we tell some parents to tell their children not to suck their thumb, because that also affects the occlusion, because it gives them the overjet, it gives them changes the bite of the child. So you've heard that, not to tell the child not to suck their thumb. It's constantly changing until you get your full permanent teeth, yes.
Oh, is sucking on pacifier as bad as
Yes, it's, sucking on a pacifier is bad as well. You're not supposed to suck on a pacifier. Now, properly aligned teeth. When the teeth are in proper alignment, it allows for self-cleansing. So it's easier for the saliva. If the teeth are all straight and in proper alignment, it's easy for the saliva to clean the whole mouth and to clean the dentition. So the saliva flows smoothly. So self-cleansing, when the teeth are in proper alignment, it allows for self-cleansing by the saliva. Now, misaligned teeth, when the teeth and the dentition are not aligned properly, they lose the ability to cleanse. So this can lead to occlusal trauma. Someone can chew on one side, they can chew on another side. You'll see when you start working in practice, if a patient has a problem on one side when they're not chewing properly, the food tends to build up on the opposite side, so then the mouth isn't cleansed properly. You'll see that when you get into practice. So it's really important for the teeth to be aligned. It also, each tooth has a specific function. So misaligned teeth, each tooth might not be able to perform the function that they were designed for when the teeth are misaligned. Centric occlusion. Centric occlusion is the position of the dentition that allows the maximum contact when the teeth come together. It's a tooth-to-tooth relationship. So basically, this is the standard. A perfect occlusion rarely exists. So we're going to use this standard. A perfect occlusion, just as a side note for you guys to know, is that there would be 138 contacts. So the teeth would be touching in 138 spots. And that would be if you have all 32 teeth. And that would be perfect occlusion. But barely anyone has that. So centric occlusion is a tooth-to-tooth relationship, just when the teeth are closed. Now, why is it important? It's important to have centric occlusion. There are other names for centric occlusion. It's also known as maximum intercuspation. They might refer to it as habitual position. They might refer to it as intercuspal position. They can say, instead of centric occlusion, acquired occlusion. Or convenience occlusion. So maximum intercuspation, habitual position, intercuspal position, acquired occlusion, convenience occlusion, all is the same as centric occlusion. It all means the same thing. It's just interchangeable words. And this is what centric occlusion looks like. Teeth are just come together, tooth-to-tooth relationship. Now, centric occlusion is important because, as you can see in this picture, all the contacts are together. There's no spaces. Each neighboring tooth is next to each other. Now, say there was a big space here, or a big space between the teeth. right? And what does, when food gets stuck in between, does anyone know what that's called? Impacted. Food gets impacted in between the teeth. So centric occlusion is important because it creates proximal contact between the neighboring teeth. It protects the interdental papilla, and it stabilizes each tooth in the arch. If the contacts are open, food gets impacted or stuck in between the teeth, and it leads to trauma or irritation to the dental papilla. So if there's a gap between your tooth and the contacts aren't properly together and food gets stuck in between, it's going to irritate your gums. So this is some more pictures, how it leads to food impaction. So these teeth are misaligned, so food can get stuck up here, plaque can get stuck here, plaque gets stuck here, and you can see how the gingiva, the color, how it's affected. There's a big gap over here. Food can get stuck up here. These teeth, when you're eating something, can push a piece of food up there. Same thing over here. You see this little space right there? Food can get stuck in there because the teeth aren't aligned. There's spaces in between here. Food can get impacted in between, so that's not centric occlusion. If they were close together, it would be centric occlusion. Okay, centric relation. Centric relation is when the mandible is in the most protruded position to which it can be carried by the muscles and ligaments. It's the most stable and most posterior position. So basically, I want you guys to do something for me right now. It's going to look a little bit silly when you guys are done writing. Centric relation is a jaw-to-jaw relationship. So it's easy to remember it. Centric relation, the mandible is protruded, relation, protruded. They both start with an R. So centric relation is when the mandible is in the most protruded position. So retruded, remember retruded, most retruded,
Okay.
and relation,
Okay.
both starts with an R.
I like that because it helps me to remember things.
Everyone's done writing? Okay, so I want everyone to open and close their mouths quickly, just like this. You notice that each time you open and close your mouth doesn't close the same, it hits something different each time, right? It hits sometimes the front teeth, sometimes the back teeth, sometimes. Now I want you to swallow and bite on your back teeth. Now swallow and bite down on your back teeth. Now do you see how it hits the same every single time as compared to the first time you tried it? So let's try it again the first time. So open and close, just each time something different, right? Now swallow and bite down on your back teeth. Do it again. It comes out the same. So that's centric relation. Now prosthodontists, they use this when they're making something for their patient because this is going to be the same bite that they're going to bite down on. This is the most accurate bite for them when the patient chews.
So retruded means that the
Mandible goes back. So when you're at the dentist, sometimes the dentist might ask you, oh, bite on your back teeth, bite down on your back teeth, because they want to get the same bite every single time. Occlusal plane. Occlusal plane is an imaginary plane placed on the masticatory surfaces of each dental arch. Does anyone know what the word masticatory means? Chewing. Good. So it's an imaginary place placed on the chewing surfaces of each dental arch. and that can be determined just from the anterior teeth. See how it's like an imaginary line from the anterior teeth, and before the slide, the occlusal plane is on the chewing surfaces. Now, the curve of speech. It's the anterior to posterior curved alignment of the teeth when viewing the posterior teeth from the buccal. So it's this curve. That's the curve of speed. So you're looking at it from the buccal, so at the side view from the cheek. If you were to retract the cheek, this is what it would look like. Now some of you might be confused. Oh, what's the difference between the curve of speed and what you just showed us? The occlusal plane, it looks the same, right? Kinda? Sorta? So we said occlusal plane is the chewing surfaces, both. When you chew, you need both arches to chew, right? So that's both. But the curve of speed is just the mandible. So it's the curve from the anterior to posterior teeth of the mandible. Do you see the difference? So if I were to standing here on the side and I pulled my cheek, and you just look at the curve. Now another type of curve is called the curve of Wilson. It's the right to left occlusal curve that exists for posterior teeth when viewed from the anterior or posterior. So if I was sitting inside your mouth, like in your throat, basically it's a cross, okay? From right to left. So before, it was the buccal view. So now, as if I'm sitting inside, I'm sitting on the back of your tongue, and the curve that goes from the posterior teeth across. That's the curve of Wilson. Does everyone understand that?
Across the tongue.
It's from
I mean,
the posterior teeth. Like I'm just saying,
One side
just
to
if
the
you,
other,
if I
from
was
right to
sitting,
left?
yeah, right to left, exactly. Now, there's something called centric working or supporting cusps. So centric working, supporting, functioning, these are the cusps that do all the work. That's all that means. Centric working, supporting cusps, these are the cusps that do the work when you're chewing. And they function during centric occlusion. And these cusps are the lingual cusps of the maxillary posterior teeth. So this would be the lingual cusp of the maxillary posterior teeth. This would be the lingual, and then it would be the buccal cusps of the mandibular posterior teeth, right there. This is the buccal cusp of the mandibular posterior teeth. So this is functioning, and this is functioning, and they're supporting cusps. Another supporting cusp is the incisal edge of the mandibular anterior teeth. You see how it's hitting? So it hits against something. So the lingual cusp of the maxillary posterior teeth is hitting into this fossa. And the buccal cusp of the mandibular posterior teeth is hitting into this fossa. Do you see how this one here and that one there is not hitting? Only these two are hitting? They're going into the fossa. Can everyone see that? Because they're functioning. They're working. This cusp right here is hitting into this incisor. This cusp is a functional cusp, this incisal edge. Do you see that, how it's working, it's hitting into something? You see how this one right there is not hitting into anything? It's non-functional. This one is functional. You see how this one right here, it's not hitting into anything? And over here, it's not hitting into anything? That's non-functional. So these three are functional. Does everyone understand that? Supporting cusp stops are usually in the central fossa. And then with attrition, does anyone know you guys know what attrition means? Wearing away when you chew, attrition. The chewing surface gets worn away a little bit. The supporting cusps are seated closer and closer to the bottom of the opposing fossa. So as in life, they get flattened out a little bit. And I just want to point out something. If something is supporting and it's working, do you think it's going to be more round, or is it going to be sharper since it's been working so much? You think the cusp is going to be, because it's functioning and supporting, you think it's going to have a rounder shape? It'll have a rounder shape, right? And the one that's not working and not functioning is going to have a sharper shape, the cusp. So this cusp goes into this fossa. The lingual cusp of the maxillary tooth goes into this fossa, and then the buccal cusp of the mandibular goes into this fossa. So the red is functional and supporting, and the green is non-functional, non-supporting. Any questions so far? So now let's go into non-centric, non-working. So the ones that don't work, the green ones, are the non-centric, non-working guiding cusps. So as I said, the buccal cusps of the maxillary teeth and the lingual cusp of the mandibular teeth are non-centric, non-working. And because they're non-centric, non-working, you see how they look a little more pointy, a little sharper? Because they're not hitting against anything. Nothing, they're not wearing away. There's no wearing away of those. Now, there's something called overjet, which is horizontal overlap. And it's how far out in front of the central incisor it is. So basically, if these are my mandibular anteriors, and this is my maxillary anteriors, overjet would be like, it would look like that. You know, they call it in commoner term, they call it like buck teeth.
Oh, okay. What if you have that, but it's like really slight? Would it still be classified as an overjet because the anterior teeth?
Well, there's going to be different measurements that you're going to measure.
So I always wondered if I had, because like my front teeth don't touch my bottom side bones. So I just didn't know if I had an overjet. So I just wondering.
So overjet, as you can see here, you see how there's a space, a horizontal space between the incisors? There's a space in between. Horizontal. Overjet, it jets out. The maxillary jets out. So usually normal amount of horizontal or overlap is usually 1 to 3 millimeters. So how would you guys measure that? Well, with your probe, exactly. So normal amount of horizontal overlap is 1 to 3 millimeters for overjet. And this is a picture of overjet. You can see the anterior teeth are jutting out in front of the mandibular incisor. vertical overlap. So if these are my teeth, and these are the mandibular anteriors, and these are the maxillary anteriors. Over bite, they would go down like this. Sometimes in patients, you can't even see their mandibular incisors because their bite is so deep. So it's a vertical overlap. How far down? It covers the lower incisors. So everyone's overbite would be different. You would also measure that with a probe. And the normal amount of vertical overlap is usually 2 to 5 millimeters. Millimeters is normal overbite. So overjet is horizontal and overbite is vertical. Everyone understand? See, you can see in this picture, you can't even see the mandibular incisors. You see how deep their overbite is? And this one, he has an overbite, but it's not that bad, but they still have an overbite.
Bruises fix that.
Yeah. Depending on how old you are, and each case is different. Now here's another picture of it. So this horizontal space here, what would that be called? Good. Now, this would be overbite. How far down? The maxillary incisor goes down to the mandibular, and overjet would be the space, the horizontal space. Any questions?
Yeah. You say like there's a normal amount for each, so you're still considered to have an overbite if it's within a normal limits?
Yeah, there's a normal limits, and then there's,
Those are still considered an overbite or an overbite?
it's considered, but in clinic, they want you, when we get up to the 4, they would want you to mark it down if it's over 4 millimeters. So that's when they want you to, when it's over 4 millimeters, that's when in clinic you have to distinguish. So measuring overbite and overjet, you would just take your probe and overjet, and you would place it underneath the space right there, under the incisor, and you would measure how many millimeters it goes across. And in overbite, you would measure the vertical overlap. So you would place the probe on the top here where it hits, and then measure the overbite. Now, malocclusion is the abnormal occlusion of the teeth. We call it malocclusion, but people, commoners, might call it crowded teeth, messed up teeth, crooked teeth. There's, well, we call each specific thing has a name, and we call it malocclusion. So don't refer to those. Don't use those terms. Yes.
You have like extraction, so you consider to have now.
If you have an extraction, it depends where the extraction is, and if they put a restorative work, like say you were to have a molar on the bottom extracted, and you never got restorative work, you never got a bridge or something,